I'm really glad to be here and to participate in this very interesting workshop. Just one slide to introduce my presentation. In the last century, the demographic and epidemiological transitions that you well know have led to very important changes at the population levels, resulting in an aged population affected by chronic diseases. Indeed, most of elderly people living in the community are affected by more than two or more chronic diseases by multimorbidity. I'm sorry for the presentation, there's something happening here, but okay, I hope the other slides will be okay. And I hope also you don't mind if I will explain you multimorbidity with this picture that I usually use for my students, where the buildings are chronic diseases, very unstable. If one collapses, then every other disease may collapse too. And the trees are the pharmacological drugs that we prescribe in order to make everything more stable, but indeed everything is floating on the water. And each of our patients may be described with a picture similar to this one, but different from all the other ones, because multimorbidity is an extremely heterogeneous and complex syndrome. So I don't think that we can comprehend multimorbidity as a whole. It would be like if you would understand the personality of this man just looking at this picture upside down at a glance. It's not possible. There's a very nice paper from 1992, so 20 years ago, by Vogt and Nagel, and where the authors tried to explain how complex information can be best recognized as patterns. In other words, if we have a large amount of data, if we reduce the data, this may help us despite a reduction also of information. And if we talk about multimorbidity, this is the identification of patterns or clusters of diseases defined as the co-occurrence of two or more specific chronic diseases. In other words, we try to study the distribution of co-occurring diseases in the population. And I'm going to show you now how we can do this, how we can identify disease clusters and also some results. And I hope that we will discuss later if this approach may be useful or not for our aims. Let's start from the identification of pairs or triads of diseases, co-occurring diseases. Among these methods, the one that I prefer is the one in the middle, is the multimorbidity coefficient, which is the ratio of the observed co-prevalence of a pair of diseases, for example, to the expected one, being the expected prevalence the one that you would get if the two diseases were completely independent. So the multimorbidity coefficient tells you the degree to which comorbid diseases exceed the chance level. And I'll show you an example from the Kungsholmen project, which is a Swedish population-based studies that started in the late 80s and ended in 2000. And I will use data from time 2 of the study because at this time, all the patients, the participants, were clinically examined by a physician, and the diagnoses were particularly accurate. 1,099 participants were examined. And we found that several pairs of chronic diseases had a multimorbidity coefficient higher than 1. This means that the observed co-prevalence of the diseases was much higher than the expected one. Not only for cardiovascular diseases, for example, hypertension and heart failure, which are very well known correlated, but also for other diseases, neuropsychiatric condition and depression, cerebrovascular diseases, and depression and hip fracture. And we use this pair of conditions that we identified with these methods in order to calculate the prevalence of disability in activities of daily living, so severe disability, according to this pair of diseases in the Kungsholmen project. And we found that the majority of disability in this population was explained by the coexistence of only 4 chronic diseases: depression, hip fracture, cerebrovascular diseases, and dementia, when they coexisted in different pairs. But using these statistical methods in order to identify pairs or triads of diseases is not enough. We need to have a complete picture of how disease distribute in the population, and we can do this using a cluster analysis. Clustering is simply the grouping of similar objects using algorithms or using measures of similarity or dissimilarity. This is the result that I got using the population of the Kung-Solman project from cluster analysis. This is called dendrogram or tree. And in the bottom part of the figure, the similarity between diseases is highest and the least in the upper part of the figure. And I like this analysis because it's best seen as an hypothesis generating rather than solving analysis. So it's up to me, the researcher or the geriatrician, to decide where I can cut this tree and which degree of similarity I want to have between diseases. So I can cut the tree at this level, and I can identify, for example, this cluster, hypertension and heart failure, on this cluster, hip fracture and dementia. But I can decide to cut the tree at a higher level and still have meaningful clusters. For example, this one, atrial fibrillation plus hypertension and heart failure, or this one, hip fracture, dementia, and depression. I will tell you how this can be useful for. But now I want to show you some other example from another study. The REPOSI study is an Italian study designed by the Mario Negri Institute in Milan and the Italian Society of Internal Medicine. It's a register of hospitalized patients in internal medicine and acute geriatric wards in Italy. The first wave was carried out in 2008 and the second wave in 2010. And we enroll more than 1,000 patients in both waves, age 65 years or older. And using this data, we found that different clusters of diseases has different effects, for example, on what? For example, on in-hospital mortality or adverse clinical events during hospitalization. In this picture, you see, for example, that anemia, the cluster included anemia and chronic renal failure, had an additive effect on in-hospital death, whereas chronic renal failure and heart failure had an additive effect on adverse clinical events during hospitalization. So the identification of clusters can be used to identify a group of patients at risk for particularly adverse outcome. Another study from the same project. These are the diseases, the most frequent diseases in this population. The model is a logistic regression model testing the association of single diseases with polypharmacy at hospital discharge. And polypharmacy was defined as the prescription of at least 5 drugs. And we identified different clusters in this population, especially one cluster was of our interest. The one included diabetes, coronary heart disease, and cerebrovascular diseases. And if you look at the odds ratio of the single diseases, diabetes has an odds ratio of 1.9, coronary heart disease 4.0, and cerebrovascular disease 1.5 of association with polypharmacy. But if you look at the cluster as a whole, the odds ratio is almost 10. Finally, from the same study, some unpublished data that I just received yesterday. In the first column, there are 4 clusters. It doesn't matter, I think, at the moment which diseases are included in these clusters, but the point is that we have calculated, according to the anticholinergic cognitive burden scale, the number of patients and the percentage of patients treated with anticholinergic drugs. And what is nice, in my opinion, is that the percentage of patients treated with anticholinergic drugs varies a lot across different clusters, from 20% to almost 90% in cluster number 4. This approach, the cluster medicine approach, is quite similar to the one that's called network medicine. This is not a planetarium. This is a human disease network, a phenotype disease network. This is from Barabasi and colleagues. And every circle is a disease, and they are linked together. And the idea is that if we observe directly the link, the coexistence between amongst diseases, this may help us to understand also why groups of diseases arise together, maybe because they have a similar molecular background. And this is probably the future, but maybe something could be done also now. And I was especially interested in the data of the Base Berlin study. Today there are really amount of data also on genetics and molecular levels. So finally, which are the research hypotheses that I can suggest using this technique? May different outcomes or prognosis in multimorbid elderly be better explained using disease clusters? Or may studies on selected clusters explain a higher risk of adverse drug events or different responsiveness? Or also, why not different costs that may be additive or multiplicative according to the diseases included in different clusters? And ideally, can we design a clinical trial aiming to change the chain of the events? That means reduce or slow down the disease clustering process, and this will result in a delaying of the onset of other diseases and a compression of morbidity in the last years of life. And finally, can this technique be useful in order to study outcome not based on disease-specific indicators, but goal-oriented patient care, such as independence and quality of life? There's a very nice paper published a few weeks ago by Terry Fried showing that if you ask an old person which is the health outcome that he would like most to preserve, 70% say independence, and the others, almost all the others, say pain relief. And I have to tell you also that this technique has some limitation, of course. The first one, which is not good talking about geriatric people, is that a quite large number are required in order to perform this kind of analysis. And the second one is that, of course, there's a residual heterogeneity inside single clusters. Thank you very much.
Thank you very much. Any question to Dr. Marengoni? Any question? Yes?
Alessandra, some pathophysiological paths are clear, some are more obscure. Have you argued, made the hypothesis of the on the links connecting, according to a traditional vision, completely different diseases enrolled, compressed in the same cluster, occurring in the same cluster?
Yeah,
because the biological or pathophysiological plausibility is a fundamental condition to be respected.
Yeah, for example, the cluster of dementia and hip fracture in the Kungsholmen project was particularly interesting because when we analyzed the incident data and not the prevalent data, we found that hip fracture came first, 6 years before dementia. So what this means? This means that, does this mean that pre-dementia diagnosis patients have already balance problems and they fall, so they get hip fracture? Or does this mean that there's some estrogen deficiency that can be linked to both diseases? So this is why I like cluster analysis, because it generates hypotheses, and especially research hypotheses like this.
maybe I missed it. Can you tell me what was the cluster that was associated with the highest anticholinergic burden?
The highest,
Excuse me?
the highest,
Yes.
the highest was hypertension, atrial fibrillation, and thyroid dysfunction.
Don't you think that this is a new pathway to refresh and run randomized clinical trials using the clusters and having a more homogeneous population in the heterogeneity of the elderly chronic diseases?
I think that this could be used in a different phase of the clinical trial. It could be used, as you said, when you design the clinical trial in order to reduce the complexity of multimorbidity population, but it can be useful also in a post-hoc analysis in order to identify which groups of persons are, for example, at high risk of adverse clinical events, or which groups of clusters of diseases had the most benefits from the drug.